Good afternoon, everyone. I'm Dr. Cricket Manotok Santiago. I'm from the Makati Medical Center, Department of Anesthesiology. And I'd like to thank you for inviting me today to give a short talk on ICU sedation management. My lecture for today is just a short refresher course on how to manage the triad of pain, agitation, and delirium, and particularly how it applies to our cardiac patients. And hopefully at the end of this discussion, you'll be able to pick up some pieces of learning and pearls of wisdom that can help you guys in your practice. So first off, I'll just give a little background on the importance of sedation in our critically ill population, as well as try to recondition your minds as to how we should be sedating our patients. So as we go on, you'll realize that we're not just dealing with putting patients to sleep, but it also deals with pain management and recognition and management of delirium in some situations. That being said, we'll also be discussing the approach to pain management and delirium and sedation based on the clinical pearls from the ICU pain, agitation, and delirium guidelines, or the ICU PAD guidelines, and how all of these are integrated into the ABCDEF bundle, which is what is being recommended for use now in the ICU. Lastly, we'll also be touching on the approach to sedation in the cardiac ICU, particularly the recommended agents for use for each cardiac condition. So the first question for you guys is, do you think ICU patients experience pain? And the answer to that is a big, fat, resounding yes. No? So pain can be experienced as a consequence of a variety of factors, including intubation and being on the mechanical ventilator itself, or routine clinical care such as moving the patient in bed, adjusting their lines and tubes. It can also be because of invasive procedures such as arterial line, or IJ catheter insertions, or Foley catheter insertions, even CPT insertions. Even if they use local anesthesia, that could still cause some significant levels of pain. It can also be a consequence of the patient's medical condition itself, such as, for example, abdominal pain secondary to gastric ulcers, or for our cardiac patients, it could be secondary to surgical interventions such as open heart surgery. So as you can see, pain can be very substantial. It can initiate elements of the sympathetic stress response, such as tachycardia and hypertension, and those are the last things that we want for our cardiac patients. So imagine being the patient and put yourself in their shoes, no? So what happens when we experience pain that it's not addressed? Diba? We become anxious, we become agitated, we become very uncomfortable, and our heart races fast and our BP goes through the roof, sometimes to the point of being delirious because sometimes we can lack sleep because of it. And ironically, all of these can actually aggravate the pain even more, and eventually becomes a vicious cycle. So as you can see, all of these three entities are closely interrelated. But among the three, it is a pain that is the most preventable, treatable, and modifiable. So if it's not treated early on, it can be a significant cause of both delirium and agitation, which would eventually snowball to more problems for both the patient and the caregivers. And that would be a much more complicated and more difficult problem to address. So as clinicians, it should be our universal goal to ensure that our critically ill ICU patients are comfortable and safe. Again, pain and anxiety contribute to an already prominent sympathetic stress response. And if this goes unaddressed, it can lead to severe agitation and to the point that the patients, you find them pulling out their tubes, putting out their vascular lines, and this can cause very significant physical and psychological stress, sometimes even PTSD in the long run. So to be able to mitigate this, our answer to that will be providing analgesia and sedation if needed. However, if given in excess, our analgesics and sedatives can contribute significantly to an increase in patient morbidity and mortality. And various data have already come out that indicated a consistent and strong association between deep sedation and poor long-term outcomes, including a prolonged duration of mechanical ventilation, plus an increased incidence of ventilator-associated pneumonia. It can also lead to increased conversion to tracheostomies, longer ICU stays, increased risk for delirium and cognitive decline, and an overall increased mortality rate. In view of this, the sedation in the critical care setting has changed in the last couple of decades with a shift to lighter sedation protocols for the management of the triad of pain, agitation, and delirium, with the initiation and emphasis on pain management first and foremost. So how do we approach PAD? No, the triad of pain, agitation, and delirium. Again, we place emphasis on pain management because remember, treatment of pain may actually mitigate the need for further sedation. We should nip it in the bud, ika nga. So how then do we address pain? And more importantly, how do we know how much pain is the patient in? So to answer this, we need validated tools in the form of scales to be able to quantify and assess the patient's pain before administering any pain relief. So the patient self-report of pain using a 1 to 10 numeric rating scale, such as the one shown here, is considered the gold standard and is highly recommended by many critical care societies. What if the patient is intubated or cannot self-report his level of pain? In these cases, we can use the behavioral pain scale or the BPS as shown, which is composed of 3 subscales. So we look for the facial expression, the movement of the upper limbs, and compliance with the ventilation. And the BPS score of more than or equal to 5 is considered to reflect unacceptable pain. There is also the Critical Care Pain Observation Tool or the CPOT, which has components similar to BPS. And the CPOT score of more than or equal to 3 is indicative of pain. So both BPS and CPOT scales can help guide us as to the selection of our agents, as well as the evaluation of their effectiveness in treating the pain. According to the ICU PAD, pain medications should only be routinely administered in the presence of significant pain. So that would equate to an NRS score of more than 4, a BPS score of more than 5, or a CPOT score of more than 3, and also prior to performing painful invasive procedures. So what agents do we use? First-line agents would be parenteral opioids. In our institution, what we use usually would be fentanyl and morphine. But keep in mind that opioids have the potential to induce tolerance over time, resulting in the need for escalating doses to achieve the same analgesic effect. So keep in mind to regularly assess and reassess the pain scores to see if there's really a need to up-titrate our doses. We also have the option of using non-opioid analgesics such as acetaminophen, NSAIDs, and low-dose ketamine. This can help reduce the opioid side effects. These are used as adjunctive therapy. Regional anesthesia can also be used, such as peripheral nerve blocks or epidural anesthesia for specific subpopulations of surgical patients. And of course, there's also the option of using non-pharmacologic methods, which are often effective and safe. So examples of this would include hot and cold compress, massage, music, and even simply repositioning the patient in the bed to a much more comfortable position would be of great help. Another important element of the PAD guidelines is monitoring and management for delirium. So it's defined as an acute and fluctuating disorder characterized by changes in perception, cognition, and attention that develops over a short period of time. And that unfortunately, it affects 60 to 80% of our mechanically ventilated patients, and it leads to longer hospitalizations and higher mortality. And it is the largest risk factor for ICU-related cognitive impairment. Unfortunately, also, so far there has been no formal recommendations on delirium prevention beyond early recognition, monitoring, and early mobilization of the patients. So how do we assess for delirium? We have the confusion assessment method for the ICU or the CAM-ICU flow sheet, which is the most frequently employed tool for the purpose of assessing and monitoring for the presence of delirium. So the patient is considered CAM positive or delirious if he manifests both acute onset or fluctuating course of mental status changes and inattention, plus either altered level of consciousness or disorganized thinking. And how do we address delirium? So if you remember in the earlier slide, we said that pain can be a significant cause of delirium, and so we treat pain as needed. Also, it helps to reorient patients and familiarize them with the environment. So we encourage them to use their eyeglasses and hearing aids as needed. It's important also to promote sleep by controlling the light in the room and decreasing nocturnal stimuli. Also encourage early mobilization, which has been the only intervention resulting in a decrease in the days of delirium. Also, benzodiazepines should be avoided because among all the sedatives, these have been proven to be a primary risk factor for the development of delirium. Of note, routine antipsychotic use such as quetiapine and haloperidol does not actually shorten the duration of delirium, or nor does it improve survival. And in fact, most antipsychotics can prolong the QT interval. So if ever you decide to use antipsychotics, the patients should be monitored accordingly. The addition of adjunctive sedatives for persistent agitation must occur only after the patient's pain and delirium have both been addressed and controlled. So if the patient still appears to be agitated despite adequate pain control and delirium has been ruled out, so that's when we can start our sedatives. And based on several RCTs, the use of the least necessary sedation translates to shorter periods of mechanical ventilator and length of ICU stay without an increase in the adverse effects. So implementation of sedation protocols using validated tools such as this one, the Richmond Agitation Sedation Scale, or the RAS scale, has been recommended by the PAD guidelines so that we can be guided as to the titration of our doses to help minimize the risk of oversedation. And a unique feature of RAS is that it relies on the duration of eye contact following verbal stimulation, and it only takes less than 20 minutes to perform. So it's very easy to administer in the ICU. It is a 10-point scale ranging from +4, which is equivalent to a very violent state, down to -5, in which the patient is already unresponsive or comatose. And in the middle is a patient that is alert and calm, and that is RAS 0. So light sedation emphasizes maintaining the patient in a state in which they are calm, cooperative, and comfortable. So we call that the 3 Cs. And ideally, the patient can be awake in order to maintain eye contact, interact with the caregivers and family members, while being able to still participate in physical or occupational therapy. And they're also still permitted to drift off to sleep when they're uninterrupted. And this state is broadly equivalent to RAS 0 to -1 or even -2. And this has been linked with very favorable outcomes. So is there an ideal sedative? Particularly one that is inexpensive, has minimal respiratory depression, whose elimination is independent of organ function, has a short context-sensitive half-life, and has no active metabolites. So that would be the ideal sedative, but unfortunately, it does not exist. And each of the commonly used drugs that we administer to our patients have their own limitations. So in the interest of time, I'll just be giving a short description of the 3 most common sedative medications that we use in the ICU, which are propofol, dexmedetomidine, and benzodiazepines. The propofol is a very potent sedative. It works by way of being a GABA agonist. It's very versatile in that it can be used for short and long-term sedation or general anesthesia, and is easily titratable. It has a fast onset and short duration of action, and it's given as a prolonged infusion, in which case the duration of action may take longer because of its redistribution from the fat stores. Although we give this drug left and right, we have to be cautious in its administration as it causes vasodilatation and negative inotropic effects, which is not so good for cardiac patients. And there's also what we call the propofol infusion syndrome, when it's given in high doses for long periods of time. It's characterized by severe metabolic acidosis, arrhythmias, cardiac failure, acute renal failures, and hyperkalemia, and rhabdomyolysis, and sometimes even to the point of asystole. So as you can see, it carries with it a very high morbidity and mortality rate, as high as 30%. So we should always be on the lookout for the possibility of PRIS in patients who are being sedated with propofol. We also have Precedex, which is an alpha-2 adrenergic agonist with anxiolytic, analgesic, and sedative properties. It's notable for its ability to provide sedation without the risk of respiratory depression, unlike propofol and fentanyl. It has no active metabolites. It does not accumulate even in prolonged infusion. But cardiac-wise, we watch out for bradycardia and hypotension, and ECG changes such as heart block and sinus arrest, and sometimes even atrial fibrillation. Benzodiazepines in the form of midazolam, lorazepam, or diazepam are GABAergic agents used for the treatment of seizures, insomnia, and anxiety. Its active metabolites accumulate with prolonged infusion and also in the presence of renal dysfunction. It's not actually the first line of agent for use in the ICU, as you will find out later on in the discussion. However, during the surge in the past months, due to drug supply shortages and the potential need for further sedation for COVID patients, its use has become more frequent. So the recommendations based on the 2013 ICU PAD guidelines recommend targeting light levels of sedation or use daily awakening trials. Also, non-benzodiazepine options such as propofol and Precedex are preferred to improve short-term outcomes such as duration of mechanical ventilator and ICU length of stay and the presence of delirium. So this holds true for both the critically ill patients and patients who have undergone elective cardiac surgery. But there may be different recommendations for the cardiac population, as you will see later on. Two large studies called the SEDCOM trial and the MEND study have recommended the use of dexmedetomidine over benzodiazepines. So in short, these considerations have influenced a general retreat from using benzodiazepines as first-line sedatives towards short-acting and easy to titrate agents such as propofol and dexmedetomidine. So as you can see here in the ICU PAD care bundle, it recommends maintaining patients at class 0 to -2. If the patient is under-sedated, we assess what is causing the agitation. So we rule out pain, we rule out delirium. And if there is presence of either pain or delirium, we treat it accordingly. If the patient is over-sedated, on the other hand, we hold the sedatives or do a sedation holiday until the patient wakes up and then resume at 50% of the previous dose. The ABCDEF bundle was formulated based on the ICU PAD guidelines. It's a way to coordinate multidisciplinary ICU care, and it represents an evidence-based guide for clinicians to approach the organizational changes needed for optimizing ICU patient recovery and outcomes. So it stands for the following: ABCDEF. And there is what we call the ICU Liberation Collaborative, which is a real-world quality improvement initiative designed to facilitate the implementation of the ICU PAD guidelines. And it strategically engages the ABCDEF bundle using the evidence-based care. As shown here, the ABCDEF bundle is implemented in such a way that it is aimed at addressing each of the symptoms of pain, agitation, and delirium in accordance to their severity as assessed by the corresponding validated tools. So how do we go about managing our patients in the cardiac ICU? Our question now is, are the current guidelines applicable to the critically ill cardiac patient, considering their more complex clinical picture and the fact that most of our drugs can have profound hemodynamic impact? Well, based on the AHA scientific statement on prevention of complications in the cardiac ICU, the general approach to management is based primarily on the ABCDEF bundle, in which pain assessment should still be the initial diagnostic step because, as previously emphasized, pain can be a direct cause of agitation and delirium. And it must be kept in mind that the pain treatment should be individualized to the underlying cause, primarily the cardiovascular conditions and comorbidities should be taken into consideration. Because while standard analgesics may be appropriate for many, the optimal first-line therapies should be one that is tailored to the underlying disease state. So for example, if a patient is presenting with ischemic pain, maybe it would be, before starting any opioids, maybe it would be more beneficial for the patient to start him on nitroglycerin instead. It is also reasonable to consider the selective use of adjuvant non-pharmacologic techniques, including massage, music, hot or cold packs, given the low risk of adverse clinical events in most patients. So there's really nothing to lose by opting to use non-pharmacologic techniques for these particular patients. Similarly, the European Society of Cardiology go a little deeper and give individual recommendations based on each cardiac condition. General consensus still remains to be initiation of pain management and control of delirium, and only when there is persistent agitation despite adequate control of pain and delirium should consideration for adjunctive sedatives be entertained. So choosing which sedative to use for each cardiac condition must be based upon each drug's inherent properties as summarized in this table. So for this slide, the discussion would be quite busy, but it would help for you to refer to this table above to correlate the drug's effects on the cardiovascular system. So we'll be discussing each cardiac condition in relation to the drugs that can be used for them. So for sedation for the acute heart failure, opioids appear to be safe, although they may lead to some level of hypotension and bradycardia through direct vasodilatation, preload reduction, and ANS modulation. But they do have neutral effects on the cardiac output and contractility. Between fentanyl and morphine, morphine has a greater potential to produce hypotension because of histamine release. The concomitant use of antipsychotics is unlikely to lead to deterioration of the cardiac performance, but it should be acknowledged that there is still paucity of data concerning its use for this population. If a sedative has to be given, benzodiazepines might be the safer option given their safer hemodynamic profile as compared to propofol and Precedex. They cause minimal reductions in the blood pressure as compared to the other two. On the other hand, propofol and Precedex may lead to hypotension through direct vasodilation, sympatholysis, and bradycardia via muscarinic receptor activation. So in summary, a patient with a failing heart would benefit from an initial sedative-less strategy, if it's possible, using fentanyl for pain control and antipsychotics for delirium management. But if an adjunctive sedative should be used or is still needed, benzodiazepines would appear to be the safer option. But again, this must be weighed. The hemodynamic advantage must be weighed against the detrimental effects on the length of mechanical ventilator, ICU length of stay, and the possibility of delirium that's associated with benzodiazepine use. For the available data for sedating a patient with valvular heart disease is still scarce, except to describe the impact of sedatives during aortic stenosis interventions. Opioids appear beneficial, but with regards to the use of antipsychotics, there's no data that exists to contraindicate it. For adjunctive sedatives, it would be wise to refrain from propofol because of its associated hypotension and reduction in cardiac output. While Precedex was found to cause more hypotension and bradycardia than propofol when it was used during TVAR. The lack of evidence precludes the formulation of specific recommendations for this population of patients. Recommendations for the ischemic heart is not entirely the same as that for heart failure management. No? Again, opioids appear to be safe given their neutral effect on contractility and myocardial metabolism, and their use seems to be associated with a reduction in myocardial O2 consumption. However, there has been evidence to suggest that there is a reduced bioavailability of the ADP receptor inhibitors such as clopidogrel and prasugrel when it is closely administered with morphine. With regards to antipsychotic use, there has been no evidence to suggest that they decrease myocardial O2 supply and demand mismatch, but we must be wary of their use immediately post-MI because of their arrhythmic effect. If a sedative is needed, again, benzodiazepines seem to be the safer adjuncts because of their milder hemodynamic effect but at the cost of the not so favorable outcomes with regards to ICU length of stay and mechanical ventilation. Propofol also seems to be they have they decrease the left ventricular myocardial workload with matched reductions in the LV oxygen consumption and myocardial blood flow, and they provide ischemia reperfusion protection. So therefore, propofol is okay to use, but maybe not for those with large areas of ischemia, given concerns that the ischemic myocardium might sustain the largest drops in the systolic function. With regards to Precedex use, there is positive data on its impact on the ischemic heart. So in summary, opiate use along with delirium management is warranted. If it is warranted, appear to still be the strategy of choice for the ischemic heart, but it is important to allow enough time for antiplatelet loading before opiate initiation to avoid any pharmacodynamic interaction. Antipsychotics are best avoided when there is high risk of ventricular arrhythmia, and propofol can be used except when there is associated cardiogenic shock or acute heart failure or a massive ischemic heart problem, for which benzodiazepines might be the safer option. For the arrhythmic heart, it's a different ballgame. So again, opiates seem beneficial for malignant arrhythmias by increasing the fibrillation threshold of the ventricle. In contrast, antipsychotics delay the myocardial repolarization. So it increases the risk of torsade de pointes and sudden cardiac death. Among all the antipsychotics, it's only aripiprazole that has not been associated for this effect. So if an antipsychotic must be used for the patient, only aripiprazole can be safe. Deep sedation is commonly used in the management of ventricular tachycardic storm. Therefore, adjunctive sedation is essential. This time, propofol appears to be safe, given its antiarrhythmic effect, but caution must still be used with bradyarrhythmias. Precedex increases the arrhythmogenic threshold as well for atrial and ventricular arrhythmias by enhancing the vagal output. And benzodiazepines have no direct effect on the conduction system except for just a minor decrease in the cycle length. So in summary, patients with arrhythmic hearts would benefit from deep sedation composed of adjunctive sedatives and opiates. And any sedative agent may be used, but this time though, it is the non-benzodiazepines like propofol and Precedex, which are preferred given their better profile and the clinical outcomes involving ICU stay and duration of mechanical ventilation and the possibility of delirium as compared to benzodiazepines. What about the post-cardiac arrest patients? Historically, opiates have been utilized safely, supported by their negligible effects on the hemodynamics. Conversely, caution must be applied for antipsychotics, especially in the presence of ventricular arrhythmias. Adjunctive sedatives is if it's needed, especially for those undergoing therapeutic hypothermia. Propofol seems to be favored over the other two agents since it offers shorter offset times compared to benzodiazepines. Also, propofol has neuroprotective effects via the scavenging of reactive oxygen species. It reduces the intracranial pressure and cerebral metabolism while maintaining cerebral autoregulation, and therefore it potentiates therapeutic hypothermia neuroprotection. There have been no studies found on the impact of Precedex for this population of patients. So in short, the European Society of Cardiology came up with this simplified algorithm to help us decide which agents to use depending on the cardiac condition present. So again, sedation goal is to keep them lightly sedated while minimizing the sympathetic stimulation by effectively providing analgesia. Sedation holidays are done each day to be able to assess readiness for weaning and extubation. The first question to ask is if the patient is in pain. If yes, we provide opioids and assess its efficacy by using the pain scoring system as discussed earlier. If the patient is not in pain, we assess if the patient is delirious, and if so, if the need for antipsychotics is warranted. Choose carefully which agent to use depending if there is high risk for ventricular tachycardia or long QTCs. If pain and delirium have both been ruled out and the patient remains to be agitated, assure first that the patient is not in acute heart failure or cardiogenic shock or has a severely depressed left ventricular ejection fraction. So if that has been ruled out, then you can start either propofol or dexmedetomidine. Remember to begin with the lowest dose possible, then titrate up slowly as needed. Otherwise, if the patient is in acute heart failure, we favor benzodiazepines, but ideally we begin with as needed boluses. But if the patient remains to be agitated, then we can start an infusion. Again, using benzodiazepines as a sedative must be weighed against the risk of developing delirium in the long run in this group of patients. Once a patient is calm and cooperative and comfortable, we go back to the start of the algorithm regularly and assess whether pain, delirium, and agitation are managed accordingly. So final question is, does deep sedation still have a place in the ICU? Well, moderate to deep sedation still remains relevant for some situations. So this includes management of severe ARDS and those with ventilator asynchrony, as can be seen in our severe COVID patients. It is also used for the prevention of awareness in patients receiving neuromuscular blockers because being awake when you're paralyzed can be very traumatic and it can aggravate anxiety even more. It is also used for status epilepticus and those undergoing targeted temperature management or therapeutic hypothermia. Also, for those patients undergoing surgical conditions necessitating strict immobilization, and for those who have severe brain injuries with associated intracranial hypertension. So in summary, if there's one thing that I hope you learned from my lecture today, it's that sedation is not always mean putting the patients to sleep. Our goal as clinicians should always be to have a patient that is calm, cooperative, and comfortable, and assess, first and foremost, assess and address pain before anything else. Early recognition of delirium with a decrease in the risk factors that can aggravate it is also of paramount importance. And lastly, if and only if we have to resort to the use of sedative hypnotic agents, we start low and go slow on our drugs, on our sedatives, so as not to burden the body, most especially the heart. So with that, I end my presentation. Thank you for your time and have a good afternoon.